Hi friends, welcome to my blog. Today we will go through normal conduction system of the heart. Normal conduction system of the heart includes SA node, AV node, his bundle branch, Purkinje fibers. As we know that SA node is a pacemaker of the heart. It fires at maximum rate and that is about 60 to 100 beats per minute. SA node is located between superior vena cava and the right atrium in the posterior wall. From SA node, first of all, the right atrium is activated. This is the right atrium, this is left atrium, this is left ventricle, and this is right ventricle. If we encircle it like this. So, from SA node, first of all, the right atrium is activated, and it is followed by the left atrium by the Bachmann fascicles. These are the Bachmann fascicles. From the SA node, impulses go to the right atrium and uh, then to the left atrium by the Bachmann fascicles. Impulses also travel from right atrium and then to AV node by these middle fibers, or we call them Wenckebach's fascicles, and they also travel to posteriorly through posterior fascicles. We call them as Thorel's fascicles. Thorel's fascicles to the AV node. So from SA node, the impulses, they first activate the right atrium, then the left atrium. Impulses also travel to the AV node through middle or Wenckebach's fascicles, or through posterior fascicle called Thorel fascicle to the AV node. Once the impulses they reach the AV node, they are slowed down so that at that time the ventricle is in the diastole. These impulses are slowed down so that there is maximum filling of the ventricle by the blood. Once the AV node is activated, impulses go down, they activate the ventricles. First of all, they go to bundle of his bundle, and they then spread to left bundle branch, right bundle branch, and then the Purkinje fibers. And these Purkinje fibers, they cause the contraction of the myocardium or the contraction of the ventricle, so that there should be uh, uh, enough blood in the ventricle before they contract. The left bundle branch, initially we thought that it divides into two fascicles, that is left anterior fascicle and left the posterior fascicles. But recently, in recent autopsy studies, we have found that the left bundle branch also divides into the left septal fascicles. And the right bundle branch, they divide into the Purkinje system or Purkinje fibers, and Purkinje fiber as a whole, they contract, and they cause the contraction of the when they are stimulated, they cause the contraction of the ventricles. The conduction through his bundle and Purkinje system is very rapid, because Purkinje system is very fast conductive system. If any impulse comes from his bundle, it's very rapid and quick. So that's why we get the QRS complexes a very rapid and sharp short duration, and these QRS complexes are usually less than 3 mm or less than 3 small squares. There are certain diseases where the SA node is non-functional or it's not functioning. Then the other parts of the heart, they have to take the responsibility for firing, and in such cases, at times AV node take its function as a pacemaker, and it fires at the rate of 40 to 60 beats per minute. 40 to 60 beat per minute. And if AV node is also non-functional, then the his bundle or the Purkinje system, they takes the responsibility of firing, and the heart beats, they fire at the rate of 20 to 40 beats per minute. This is important because when in some diseases, if SA node is not functional and AV node is also not functional, then the Purkinje system, they come into action, and they start contracting, or they help the heart to contract at the rate of 20 to 40 beats per minute, so as to maintain the function of the heart. And this whole process is called the automaticity. So this is the normal conduction system of the heart. From impulses travel from SA node, which acts as a pacemaker, travels to the atria. In atria, it travels first to right atrium, then the left atrium, then it goes to AV node, where there is delay, so that the ventricles have sufficient time uh, in the diastole, and more blood fills the ventricle. Then impulse from the AV node goes to bundle of His. From bundle of His, impulses travel to left bundle branch divides into left anterior fascicle, left posterior fascicle, and left septal fascicle also. And these further fascicles further divide into Purkinje fibers, and they cause the contraction of the left ventricle. Similarly, bundle of His divides into right bundle branch further divides into Purkinje fibers, and Purkinje fibers, they cause contraction of the right ventricle via these if the impulses, they come to it from the right bundle branch. So SA node has a capacity of firing at 60 to 100 per minute beats per minute. AV node has 40 to 60, and Purkinje system has 20 to 40 beats per minute firing capacity. As we know, the heart or the myocardium has cylindrical cells, and in between cells we have intercalated disc. These intercalated discs have gap junction. These are basically gap junction, which acts as an electrical window for the conduction system. And these gap junction allows the impulse to travel from one cell to another, and through a special protein called connexin. Let us discuss about the action potential in the myocardium. Action potential in the myocardium or myocardial cells, and action potential of the pacemaker cell, that is SA node or AV node, is totally different, and how they react to the changes in the electrolytes. In myocardial cells, the phase 4, it is the in the phase 4, it is in the this is the resting membrane potential, but in pacemaker the depolarization occurs in the phase. In myocardial cells, the phase 4 is the resting membrane potential, but in pacemaker cells the depolarization occurs in the phase 4. That is, it has funny channels. uh, it has a funny channels. These are the funny channels through which the funny current flows. When it's the potential is about minus 80 to minus 60, the funny current flows, and its positivity starts increasing. And when it reaches about minus 60 to minus 65, the sodium channels opens, and sodium channels, when sodium enters the cells, it increases its positivity of the cells. And when it reaches about minus 55 to 50, minus 50, then the calcium channels opens. And when these calcium channels open, the calcium start entering the cells. It raises the reaction potential, and at the top, at this point, the calcium channel they close, and potassium channels, they start opening, and the potassium starts moving out of the cells, and it causes the repolarization of the pacemaker cells. potassium moves out, repolarization starts, and its membrane potentials starts decreasing. Again, when it reaches uh, minus 65 to 70 or 80, then the phase 4 uh, stage occurs, and further the funny currents flows and the spontaneous depolarization occurs. So this is how the action potential is seen in the sinus, this SA node cells. One important thing to remember is that these uh, funny currents or the funny channels, they can be blocked with drugs so as to reduce the heart rate. If the heart rate is reduced, the diastole is prolonged, and this is especially useful in the heart failure cases where we decrease the heart rate by the drug called ivabradine. The drug is ivabradine. Um, Ivabradine means it causes bradycardia. Eva means it blocks the funny currents, and these funny currents phenomena is also seen in eyes, in the retina of the eyes, and it causes luminous effects. So the patients who are put on this ivabradine, they also have this luminous phenomena in their eyes, which I will discuss in later stages. Let us see the action potential of myocardial cells in phase. This phase 4 is the depolarization stage. Phase 0, the sodium channel open. Sodium channel open means sodium entry occurs. Then there is a phase 1, the sodium channel they close. Potassium channel they open. Potassium efflux occurs, and thus here the balance is maintained, and because of this balance, plateau phase is attained. uh, so in phase 1, the sodium channel they close, potassium channel open. Potassium efflux occurs means potassium moves out, positive charge moves out, but at the same time the calcium also enters. The calcium channels they open, and it maintains the uh, overall balance. And this due to this, the plateau phase is achieved in phase 2 because of entry of calcium and the movement of the potassium. Before the start of the phase 3, the calcium channel they close, but a potassium movement or potassium efflux uh, is more and more potassium comes out of the cells, and it causes repolarization of the cells, and repolarization of the cells is seen in the phase 3, and then occurs the phase 4, and this is the resting membrane potential, the resting membrane stage. I hope how the electrolyte changes they cause disturbance in the conduction system, or how they maintain the conduction system of the heart is clear to you, both in at the level of myocardial cells and at the level of the pacemaker cells. If there is any disturbance in the electrolyte balance in the body, or whenever there is electrolyte abnormality like hyperkalemia, hypokalemia, and other sodium, potassium, when potassium and calcium they play very important role, as and also sodium, in maintaining these action potentials of the heart. If any disturbance is there in these electrolytes, the patient can lead up with the arrhythmias, which can be very fatal if they are not treated. Let us discuss about the leads and the electrodes system. We were saying that depolarization, repolarization. Actually, what is depolarization? Depolarization basically it is increase in the positive charge inside the cells, increase in the positive charge inside the cells. And what is repolarization? Repolarization is increase in negative charge or decrease in the positive charge inside the cells. And what is vector? Vector is any substance which has a magnitude and direction where it is going is hamesha positive, is in the positive direction. Direction is direction where the vector goes, it is in the it is toward the positive side, and this is the vector. Suppose these are the cameras which we have placed to see how the conducting system works, how we get positive and negative deflection during depolarization and repolarization. Whenever a positive charge moves towards a lead, this is like, suppose this is lead camera. Whenever the positive charge moves towards a lead, we get a positive deflection, like we see. And whenever a positive charge move away from the lead, we get negative deflection. And if any lead is placed perpendicular to the direction of the vector, we get first positive deflection, then we get negative deflection. Because why first positive? Because initially the positive was here, now it's moving away. Initially positive was here, now it is moving away. Because of positive we got positive deflection. When it moves away, we got negative deflection. We can just see why we get positive deflection. Suppose I am here, and if any positive news comes to me, or my friend person who is very positive comes to me, I feel happy, I feel activated, I feel more happy. Means my positivity starts increasing. And suppose I am here, if any my positive friends goes away from me, so I will feel sad. I will feel it's sad, because positivity is going away from me. And then there will be a negative I will feel sad, or there will be a negative deflection in ECG if the positivity goes away from the leads. I hope you are clear. Whenever there is the positive charge or vector with the positive charge goes close to the lead, it gives a positive deflection. Positive charge if goes away from the lead, we get negative deflection. And if any lead is placed perpendicular to the direction of this vector, we get initial positive deflection, then we get negative deflection. Let us discuss about the waves, intervals, and the segments. This is the P wave, and this is QRS complex. This is the T wave. This is small U wave. Uh, Before discussing about the various waves and intervals segments, we must know when one or more waves are there, like this is also wave, this is also wave, this is also wave. When one or more waves are there, we call it as a complex. We call it complex. And all these waves, whether it is QRS, T wave, U wave, all they represent the specific electrical activity of the heart. The P wave represents the atrial depolarization, that is the electrical activity of the both atrias, right and left. When they contract, they produce P wave. The SA node activity is usually silent. We don't get any SA node activity in ECG. QRS complex is due to the depolarization of the ventricles, and T wave is due to the ventricular repolarization, and U wave is at times seen due to the depolarization of the papillary muscles, which I will be dysfunctional hypertrophic papillary muscles, which I will discuss in later stages. Let us see how these waves they are formed. If we see our chest, inside of the chest from top, that is the horizontal section, we see how does this is the basically spinous process, spinal cord, vertebrae, and this is the heart. And this is the right ventricle, this is right atrium, this is left atrium, this is the left ventricle. This is how our heart appears from the top in the horizontal section. Whenever the SA node is fires SA node fires, the first of all the right atrium is activated. We can see here the SA node is activated. The impulse go to right atrium, then it goes to left atrium. This is the position of vectors, how they travel to right atrium and the left atrium, then it goes to left ventricle and the right ventricle. Suppose a lead is placed over here at the on the chest. As we know, first the impulse is going to the right atrium. It is means going to the right atrium. It is close to the this lead, so we will get a positive deflection. And secondly, when it is going away from this lead to the it is going to the left atrium, we will get a negative deflection. This is basically P wave. This is P wave. First positive deflection, then it is negative deflection. It is usually seen in V1 to V3, V1, V2 and V3, and it is called biphasic P wave. Biphasic P waves, these are seen in the V1, V2 and V3, and these are common. So biphasic P wave, if we see here, this is due to the contraction of the right atrium, and this is due to contraction of the left atrium. Contraction means depolarization of the right atrium, and this is due to depolarization of the left atrium, and it is called biphasic P wave. Biphasic P wave, it is very common in V1, V2 and V3. V1, V2 and V3. Whenever we see such waves, biphasic P wave in V1, V2 or V3, we should not get confused that it is any abnormal thing. It is a normal biphasic P waves. These are normal in V1, V2 and V3. So we saw that the impulse travels from SA node to right atrium, then left atrium, then it goes to septum, left ventricle, right ventricles in these direction, and we will see how the QRS complexes are formed in next slide. It is a cross section of the ventricles of the heart, and we will see how the QRS complexes are formed. It has a very peculiar way of activation in the ventricle system of the heart. First of all, we will see the initial activation is in this direction. So this V1 is the initial vector, and this is the main vector, and this is the terminal vector. So the initial activation is in this direction. If we place a lead here, or we can say here, because it is a cross section, so we will see that the impulse is moving away from this lead. So the initial deflection we will get like this, small Q wave. Why did we get negative deflection? Because the impulse is going away from this lead or this lead, so we get since impulse is moving away from this lead, we get a negative deflection, that is a Q wave. Now if we see that majority of the vector is moving in this direction. Why? Because this is the left ventricle, and this is the right ventricle, and this is the septum. If we see the mass of the left ventricle, it is quite large, or more than the right ventricle. So the because of more mass or more net direction of the vector will be in this direction, though it will be going like this, like this, like this, like this, like this, but since mass of the left ventricle is quite more than the right ventricle, the net direction will be in this direction. And since this if we see the placement of the lead is this leads, the vector is coming towards the lead, it will give a large deflection. So the initial deflection will be small q wave followed by large r wave. After we get this main direction of the vector because of high mass of the left ventricle, more mass of the left ventricle. Now the impulse also go to posterior part or basal part of the heart, and since they will move away from the if this is the lead, impulse is moving away, we will get another negative deflection, and this is the S wave. This is Q, this is R, and this is S. This is how QRS complex is formed. Q wave is due to the activation of the septum. Since if we place a lead here, it is moving away from the lead, we get a negative deflection. More positive deflection of R wave is due to the position of the main vector. Main vector is because of left ventricular mass, which is more than the other parts of the heart, like right ventricle or the septum. So the net direction of the heart, net direction of the vector is towards the left ventricle. We get a positive deflection. Then impulse, after activating this, impulse goes towards the base of the heart or posteriorly. We get thereafter we get the negative deflection. This is how the QRS complexes are formed. Let us see what is tau wave. Tau wave is basically we see that what is the basic difference between depolarization and the repolarization? In depolarization, basically simultaneously multiple cells or sites they are activated simultaneously, but repolarization that spreads very slowly, one cell to other cell, third cell, fourth cell. It is basically a slow process. And depolarization is from endocardium to epicardium, and repolarization is from epicardium to endocardium, means from out to in, and depolarization from inside to outside. So if we place electrode over here, the depolarization wave means positive charge is moving close to the lead, we will get positive deflection. And similarly, if we place electrode over here, the positive charge is moving away from the lead, we will get repolarization. We see the negative charge is moving away from the lead, so we will get another positive deflection. This is why T waves are, though they represent the repolarization, they are positive, means they show positive deflection because the negative charge is moving away from the epicardium to endocardium. Let us discuss about the QT interval. We should be very much aware that QT interval prolongation causes arrhythmias, and at times it can cause sudden death also. And how QT interval is measured, we have to draw a tangent or a sloping line from this T wave to the baseline, and we have to extend this isoelectric line or baseline, and the point where it this tangent and that baseline meet, it is the end point of T wave. So the QT interval is time between distance from the start of the Q wave to the end of the T wave. This is the QT interval. Similarly, if there is some condition, we find there is ST elevation, like we see here, this another wave. This we have to take tangent from this, not from this, not from this. You have to draw a tangent from this point. We took a tangent here because the another wave was very close to the baseline. Had it been there, we could not have made out the QT interval. That's why we took this tangent here. Since it is very high and we can't say that it will come here, that's why we took tangent from this wave to that, and where it crosses with the this isoelectric line or baseline, we get that the end of the T wave. That QT interval is from the beginning of the Q wave to the end of T wave. Similarly, we can see the PR interval. PR interval will be from the beginning of the P wave to the beginning of the QRS complexes. Beginning of the P wave to the beginning of the QRS complexes. So what are the intervals? Intervals will be anything which will have one wave and one isoelectric segment. We can see here, this is a wave and this is the isoelectric segment, that is PR segment. And similarly for QT interval, this was a Q wave, this was wave, and this was isoelectric segment, that is ST segment. So interval will have one wave and one isoelectric segment. These are the various components of the heart rate. Heart rate is 60 to 100 beats per minute. This is normal. PR interval is 0.12 to 0.20 seconds. Usually it is 3 to 5 small scares. QRS interval, it is 0.06 to 0.10 second. This is usually less than 3 small scares. QT interval is usually less than half of the RR interval, and ST segment is 0.08 second. These values we have to remember, and it helps in basic interpretation of the ECG. Coming to the QT scale or QT prolongation, this is the normal QT, and its value is about 360 in male and 370 in female. Normal values. These are the normal values. And the very long QT, or we can say long QT syndrome, it is basically a genetic disorder and seen in some people, and it is an important cause of arrhythmias. But we have to exclude the secondary causes of the long QT syndrome. Similarly, short QT syndrome is also seen, and it is also a congenital disorder, and the short QTs is also seen in hypercalcemia. If the calcium levels are increased in the body, it can cause short QT syndrome or short QT, and it is important cause of. Hope you understood the basic conduction system of the heart. Please read these books for better understanding of the ECG. Thank you very much.